so much. So thank you, AIOS and Dr. Hamadri, for making me a part of this session. I'll be speaking about scleral buckling in pediatric retinal detachments. I'm actually not able to somehow change the slide.
Mouse click करें एक बार.
Mouse. Yeah, sorry. Yeah, thank you. So coming to the introduction, pediatric vitreoretinal surgery is different and it's very unique. One should be familiar with the anatomical and structural characteristics of the pediatric eye and with respect to its age. The visual outcomes in these patients are usually poorer because of long-standing detachment, or maybe they come up very late. And thirdly, even after good anatomical attachments, we kind of see amblyopia. So, and post-surgical, what I have said, that post-operator monitoring and visual rehabilitation is of paramount importance. The characteristics of pediatric retinal detachments is they have usually macular involvement, which is seen up to 60 to 85% of the times. They have a chronic course, as I said before, because the children are not aware of the detachments or the decrease in vision, and they are actually picked up during school screenings or maybe picked up by their parents when the patient is actually going into more of squinting. These patients actually have proliferative vitreoretinopathy at presentation, where it is almost seen in 20 to 60% of the patients. These kids actually have bilaterality with almost to 30%, and that is what we had discussed in the previous talk also, that they can actually present with undetectable retinal holes. They are very difficult to actually examine. So we may miss out on holes, and that can actually lead to resurgeries and redetachments. Male have more preponderances, and these patients do have some systemic comorbidities also. So some tips is like, we should definitely ask for history of prematurity, presence of any infections before, systemic involvement if any, and history of trauma, which is of most important. If a child comes with history of squint, nystagmus, hypotony, or any cataract, we should consider that the child is possibly having PVR. Pediatric retinal detachments can be of all the three types, which we have discussed, rhegmatogenous, tractional, and exudative types. We are going to talk about more about rhegmatogenous types in this presentation. Coming to pediatric rhegmatogenous RD, here we actually have the percentage is almost 5 to 8% of the total RDs of rhegmatogenous which we see. The most common causes are trauma, myopia, and previous intraocular surgery is of an independent cause for these sort of detachments. The previous surgeries could be a cataract surgery or a glaucoma surgery. And congenital development anomalies can be seen in almost 50 to 65% of the patients. Continuing with developmental disorders, we have the Stickler Syndromes. What we need to understand is these sort of patients have bilateral rhegmatogenous RDs in almost 50% of these times. So when we are getting a child with this Stickler syndrome, we should examine the other eye, and we should do a prophylactic laser 360 degrees if possible. If a patient comes with Marfan syndrome, we should be aware of thin sclera, and where we should take into account whether we should actually go in for doing a buccal or vitrectomy. The others being FEVR and choroidal coloboma. So why to do a scleral buccal in pediatric patients, and why not vitrectomy? The most common thing is vitreous is more formed in these kids, and it gives a good tamponade over the retinal breaks when the tractions are released by the buccal support and indentation. There are multiple studies which has put up that we have a very good anatomical success in these sort of patients, up to 90%, even if they have presence of PVR. And we have seen that scleral buckling plus vitrectomy, or maybe scleral buccal alone in these patients, is better than vitrectomy alone. Secondly, if we actually try to go in for doing a vitrectomy in these kids, what happens is basically there is difficult separation of the hyaloid, which is found out because of the tight adhesiveness of the vitreoretinal junctions. And these hyaloids kind of contract and they lead to more PVR. Secondly, we are not able to actually elevate the posterior hyaloid above the level of the anterior border of the break. the amount of vitreous kind of contracts, and it can lead to reopening and redetachments. And when we are actually doing a vitrectomy in kids, we actually have to do lensectomies, we have to do retinectomies, and then again we have to put in oil. So overall, the visual outcomes are very poor. Now, when ideally one should do a scleral buckle is basically when we actually have a very clear lens, the breaks are mostly anterior, and there is usually no presence of PVR. The types of buckling which we can do is encircling circumferential bands, or maybe a segmental limited bands, or maybe a radial buckle. I prefer doing a segmental limited circumferential buckle in most of my cases. So the principle of repair has been nicely discussed by the previous speakers, but what is of utmost importance is to examine the other eye when we are actually going in for the surgery of these patients. You can do it in the OR, where you can actually examine the child under anesthesia, look in for any breaks, and you can do a subsequent laser and subsequent follow-ups. Now, coming to the technique, what have been discussed before, what normally, ideally, you can do it in an older child, or maybe like 15 years, less than 12 to 15 years, is like when you put a buckle, the lateral extension should be 2 millimeters away from the breaks, and at least the posterior should be 3 millimeters. If you have an anterior break, the buckle extends from the aura, and if you have a posterior break, at least 3 millimeter anterior clearance is required. Sometimes with the breaks, we tend to have a lot of vitreoretinal tractions, and in that cases, we can have an encirclage of what we use is 240 bands that can help in support. Coming to the width of the buckle, in younger children, what at least should be done is like the width of the buckle should extend from the aura to the posterior edge of the retinal break. The buckle should be precisely on the retinal break. That would actually help us in having a good, successful anatomical outcome. And these children may have later on possibly a vigorous reproliferation or a PVR. So a higher or tight sort of a buckling is required so that we can have prevent from recurrences. So this is one of the surgeries which I want to talk about. This is a pre-op case. We can see that the child, 13-year-old child, came with a retinal detachment, a high myope, and we can see there was a flat SRF, and there were multiple breaks seen in the 2 to 3 clock hours and 4 to 5, which is not seen in the photo, but he had multiple lattices around 2 to 3 millimeters from the aura. And we went ahead and did a buckle. Here in the video, I would want to explain that we did an inferior drainage. The marking of the breaks and cryo is not actually picked up in the video. So we have drained the fluid as much as we can. The endpoint is when there is some egress of pigments, or maybe the blood starts to ooze out. That is the endpoint. And then we have done a temporary banding, and then this a segmental buckle is used, and we have placed the buckle. 276 buckle is used here, which is an asymmetric buckle, and we have the extent is almost from 12 o'clock to close to 6 o'clock. And then we have fastened the scleral buckle. We have put the 240 band over it, and then we have tagged the muscles. We have done the tagging. 2 muscle tag has been done in the between the superior rectus and the lateral rectus, and 1 tagging has been done in the inferior quadrant between the lateral rectus and the inferior rectus. This is followed by tagging of the 240 band, and finally we do anchoring sutures at supranasal quadrant. And in most of these cases, one should always do a paracentesis, and we can do that. And this is how the result was. This is another case which had a supratemporal break following trauma, which we can see that there is a good break cryo marks and good retinal attachment. Now, coming to some special circumstances of scleral buckling with vitrectomy, that if you have a younger child infant who has a retinal detachment, we can actually put a 40 number band or a 240 silicon band that can be used, and that bands are actually placed anterior to the equator. Scleral belt loops of making sleeves for passing the 240 band should be avoided. Better to do scleral suturing. In ROP-related detachments, the bands are basically placed to support the ridge. The anterior portion of the 240 band is basically supporting the ridge. So the band is placed slightly more posterior. And if you want to provide the height, the sutures can be imbricated in these patients. Coming to Chandler illumination, Dr. Vaibhav has nicely explained about it. The rule of thumb is actually placing when the child is more than 4 years of age, it should be at least 4 millimeters. In children less than 1 year, I would prefer 1 to 1.5, 2 years, 2 millimeters, and 3 years, 3 to 3.5, so on and so forth. And what the advantage is what Dr. Weber has nicely explained about. What I was emphasizing is like since the children are very difficult to examine, we can actually identify undetected breaks, and that can actually help us in identifying and having a proper attachment of the retina. Here you can see the cryo marks have been nicely been done, and the retina appears attached later on. The disadvantages in pediatric patients would be sclera appears to be very thinned out. So you do have to actually, when you take out the ports, whether it is 25, you should suture it to improve, to avoid infective end-off. If you use a 27th, you may just get away with it. So post-operative complications could be limitation of eye growth, for which you can divide the encircling bands after 3 months in children less than 2 years of age, or those who have eye growth which is retarded. And the other most possible complications is amblyopia, for which a very good rehabilitation should be done. Just another slide to add for vitrectomy for pediatric retinal detachments. These are some indications: poor fundus view, giant retinal tear, extensive PVR, and most commonly total retinal detachment with extensive RDs. Your primary indication would be to do a vitrectomy. So to conclude, we should have a thorough history before the surgery, where it should include a birth history, medical, family, and ocular surgery. There should be a systemic examination, and there should be extensive counseling about multiple surgeries, and even though you have good attachments for amblyopia. And finally, you should have excessive or amblyopia therapy. Thank you. Thank you, everyone. And I would acknowledge Dr. Dipender and Dr. Divyansh for their videos. Thank you.